diencephalon. The anterior end is narrow and it forms the posterior boundary of interventricular foramen. The posterior end is expanded and you can see it right here. It is the expanded portion called pulvinar and it is overhanging the colliculi, the lateral and medial colliculus, geniculate bodies. They are overhang and these are geniculate bodies and is overhanging the colliculi. The superior surface of the thalamus, it is related on the medial aspect, it is related to the choroid plexus, tilia choroida of the third ventricle and the fornix, and this lateral ventricle. On the lateral aspect, it is related to the floor of the lateral ventricle, the body of the lateral ventricle. And if you want to go into the more detail, there is choroid plexus and tilia choroida of the lateral ventricle, there is internal cerebral vein, and there are thalamostriate vein, the stria terminalis. All of these structures are present on the superior surface of thalamus. Again, a reminder, a detailed discussion of the presence of these structures was done in lecture of diencephalon. If you are feeling lost, I would recommend you to view that video first. Inferior surface, anterior aspect, it is related to the hypothalamus. Here it is anteriorly, it is related to the hypothalamus. You can see hypothalamus right here too. If you see from the posterior aspect, it is related to the midbrain. So it is inferior surface hypothalamus anteriorly and midbrain posteriorly. The medial wall of the thalamus, it's this wall. So this is the medial wall. The prominent structures that you will see, the most prominent structure will be the interthalamic adhesion. It is making the lateral wall of the third ventricle. This is the third ventricle. It is making the lateral wall of third ventricle, and you will see this hypothalamic sulcus, this trimedullaris thalami. These are the structures that are visible on the medial aspect of the thalamus. On lateral aspect, the most prominent and maybe the only structure that is very visible, that is the internal capsule. These are the fibers coming to and from the cerebral cortex. So what are its relation? On the medial aspect, there is third ventricle, interthalamic adhesion. On the lateral aspect, there is internal capsule. On the superior aspect, from medial to lateral, choroid plexus, third ventricle, fornix, lateral ventricle body with choroid plexus and internal cerebral vein and thalamostriate vein, stria terminalis. So all of these structures are present. Most laterally, there is caudate nucleus. Inferiorly, there is hypothalamus anteriorly and here and midbrain posteriorly. And infralaterally, there is subthalamus, not very visible in this picture. Anteriorly, it is seen here, that is the foramen of Monroe, it is seen here, and anterior to it there is fornix. Posteriorly, its own end, that is pulvinar, and this is the pulvinar and epithalamus consisting of pineal gland and habenular nuclei. These are the pictures from Snell's anatomy, and I will be discussing now the different subdivisions, different nuclei, and we will then go on and discussing each of the nuclei individually. So the major landmark that is dividing the thalamus and that is very visible, if you have not seen it, you will see it again. This Y-shaped structure that is present running throughout the thalamus. If you did not notice it before, here is that Y-shaped structure that is present right here. So it was present in a lot of images before, but now you know it, now you will see it. So this is intralaminar, internal medullary lamina, and due to this Y-shaped structures, this internal medullary lamina, this Y-shaped structure, it divides the whole of the thalamus into three major parts. Between the two prongs, there is anterior. On the medial aspect, there is medial, and on the lateral aspect, there is lateral. As you can see, it's not a single line, it's a whole plane that goes down. So it divides the thalamus into the medial and lateral aspect, and you can see from this picture Most of the nuclei are present on the lateral aspect. On the top, above thalamus and below the lateral ventricle, there is a layer of white matter that is called stratum zonale. I have drawn myself here, and here you can see in the picture on Snell's neuroanatomy on the upper aspect below the lateral ventricle. This part is called stratum zonale. On external aspect, on lateral aspect, there is a layer of white matter between thalamus and the internal capsule. This is called external medullary lamina. So this structure is external medullary lamina that is technically separating the thalamus from internal capsule. Up till now, I did not go into this detail very much, but because it seemed irrelevant and it seemed at least overburdening. But now, as we are discussing thalamus in more detail, I'll show you. In the upper aspect, there is stratum zonale. On the lateral aspect, there is external medullary lamina. And a nucleus of thalamus, there is a nucleus of thalamus that is a red nucleus, it's a reticular nucleus that is present right here. And just keep in mind, it is present outside, it is present external to the external medullary lamina. So these are the few things that you will see when reading a book. So I wanted to give you a heads up. Let's us see the different nuclei of the thalamus. This is again a picture from Snell's neuroanatomy. On the anterior aspect, there is one major nucleus, that is the anterior thalamic nucleus. On the medial aspect, there is again one major nucleus, that is dorsomedial nucleus. Technically speaking, there are a series of different nuclei, but due to their similarity in functions, we are considering them as a common group, the dorsomedial nucleus. At this level, we are not going into any further detail than this. Lateral part has two tiers, dorsal tier. For the brain, by the way, if you keep in mind, for the brain, the part towards your hair, that is the dorsal aspect. The part towards your eyes or towards the base, that is the ventrum. So for brain, that is dorsum, and that is ventral, and that is rostral or cranial, and that anterior or posterior, it's a better word just to avoid any confusion. This is anterior, this is posterior. I am using these words because in the abdomen and the other thoracic region, anterior is ventral and posterior is dorsal, but in the brain it's not the case. Here in this part, that is divided into two parts. This whole region, this is the dorsal tier. It consists of the lateral dorsal nucleus, lateral posterior nucleus, and pulvinar. And the rest that is below it, that is the ventral tier. And from front to back, there is ventro-anterior nucleus, ventrolateral nucleus, ventro-posterior nucleus, further divided into two parts, ventro-posterolateral, ventro-posteromedial, and then there are other nuclei that do not fall into this classification, like intermedullary nuclei that are present within the internal medullary lamina. There is nuclei of midline, majorly present in interthalamic connection, and geniculate bodies that are present on the posterior-inferior aspect, and reticular nucleus that is, interestingly enough, physically separated from thalamus through external medullary lamina. So this classification is shown in a neat way by this is a picture or flowchart from Inderbir Singh's neuroanatomy, and this shows the division of thalamus into different nuclei. Okay. So functions of thalamic nuclei. Now we will go step by step with each of the different thalamic nuclei. We will see its connection, its function, and how do they play their part. So let's start with the anterior nucleus, and that is the nucleus that is the thalamic nucleus that is present between the two limbs of the internal medullary lamina. It is very closely related to the limbic system, and due to the functions of the limbic system, it is concerned with emotional tone and learning and memory. So it is related to that. It is a part of Pepys circuit, again a part of discussion of the limbic system. So major afferents, major input it gets are from hypothalamus, especially the mammillary body of the hypothalamus, and it reaches by mammillothalamic tract. The signals from the hippocampus, hippocampal formation, they reach it via fornix, and the connections with the hypothalamus are reciprocal, so there are to and fro signals going in either direction. And this is a picture from BRS neuroanatomy, and the output majorly goes to the cingulate gyrus. This yellow area, this part of the brain, that is called cingulate gyrus, a major part of the limbic system. Then there are dorsal tear nuclei. There is lateral dorsal nucleus. There is lateral dorsal nucleus. There is lateral posterior nucleus and pulvinar. But before going into that, let us finish this part first. The medial aspect, that is the dorsomedial nucleus. So dorsomedial nucleus, it's the part on the medial aspect, on the medial side of internal medullary lamina, and that is a site for integration of gathering of a large amount of sensory information, and it relates this information to the one's emotional feeling, emotional states, and all these sensory informations, they generate some emotions that is occurring here, the subjective state, the emotional state that is generated through here. And the information integration is majorly through olfactory, visceral, somatic, and one way, I think it was Dr. Najib or someone, it says the physical manifestations of the emotions, your heart rate raises, or your these structures, these changes. So this is majorly related to emotions, and injury or lesion to this will lead to decrease in anxiety, decrease in tension, aggression, and much like the functions of the prefrontal cortex, the emotional functions. It is related to the memory too. There is Wernicke-Korsakoff syndrome, and this is the memory loss. It is getting input from amygdala, temporal neocortex, part of both part of limbic system, olfactory areas from the temporal areas. Substantial diagram. There are connections with the hypothalamic nuclei, other thalamic nuclei, and major output is to prefrontal cortex. Although it is reciprocally connected, now let us talk about dorsomedial nucleus. This is the nucleus that is present on the medial aspect of internal medullary lamina. It is a series of nuclei and has very diverse function, not very clear, but the consensus is that it integrates a large number of sensory information, and with that information it relates it to one's emotional feelings and subjective states. So if you get some sensation and after that you feel pleasant or you feel angry, so a lot of it is through dorsomedial nucleus. And the olfactory, visceral, somatic functions and different sensations are integrated here, and somatic and visceral reflexes are mediated through this point. Injury to this nucleus may lead to decrease in anxiety, decrease in tension and aggression, much similar to that of the injury of the prefrontal cortex. And injury also leads to the loss of memory, Wernicke-Korsakoff syndrome. It gets signal from amygdala, from the limbic system, temporal cortex from the limbic system, olfactory areas, substantia nigra, connected to the thalamus, hypothalamus nuclei, and major output is to the prefrontal cortex. Let's move on to the dorsal tear nuclei, and these include the lateral dorsal, the lateral posterior, and the pulvinar behind it. The lateral dorsal nucleus. This nucleus, it is present anatomically. seen separate from the anterior nucleus, separated by internal medullary lamina, but it is a you can just consider it a displaced nuclei of the internal medullary lamina. So it will have similar function, similar connections. It will getting its signal from the hypothalamus through mammillothalamic tract, from the hippocampus through fornix, reciprocal back to the hypothalamus and to the cingulate gyrus output major 2. And these are the signals to and fro, and it will be responsible for emotional states and memory majorly. Lateral posterior nucleus, and it is having a role in visual and spatial attention regarding space, your 3D space. So it gets its inputs from the sensory areas that are sensory relays, that are ventroposteromedial nucleus, ventroposterolateral nucleus, and it communicates with the superior parietal lobule. And you can, by the way, pick this mistake and comment, send a message to the BRS book. So it is labeled lateral posterior nucleus, but you will have to label lateral posterior nucleus. Actually, it's labeled wrong here. Ventral posterior nucleus, it's lateral posterior nucleus. It's Pulvinar. This is the largest of the nuclei present on the posterior end of the thalamus, and it is concerned with visual attention, appropriate motor activities in coordination with oculomotor function. So it is called visual lower visual center. So it gets its signals from its lesion leads to the sensory aphasia, and it gets its signal from geniculate bodies through superior colliculus, and it is in connection with the sensory association cortices. Those are present in the parietal area, in the occipital area, and the temporal area. So it is in connection with those shown here too. Now this brings us to the ventral tire nuclei, and that will include ventral anterior nucleus, ventral lateral nucleus, and ventral posterior nucleus that is further divided into ventral posterolateral and ventral posteromedial. Ventral anterior nucleus, it influences the activities of the motor cortex, and it is majorly connected with the basal ganglia, basal nuclei. So it is getting information from globus pallidus, substantia nigra, especially the pars reticularis part reticular formation, and its output, its efferents are going to the premotor area. So the part that is premotor area, that is anterior to the primary motor area. You can see it on the lateral and medial aspect. So this include both the pre and supplementary motor areas. It is reciprocally connected to the both basal ganglia and the brain, and the major pathways are shown with the solid line. The ventral lateral nucleus is the ventral lateral nucleus. It has connections very similar to those of this ventral anterior, and it influences the motor cortex. It influences the activities of motor cortex and striatal motor system, that is the basal ganglia, in addition to its cerebellum. Now it's added, and its lesion destruction reduces Parkinson tremor, and that's sometimes therapeutically used too. Again, not very commonly, but so it has connections to the basal ganglia, globus pallidus, substantia nigra, reticular formation. Additionally, major connections input from the cerebellum and minor from the red nucleus of the midbrain too. And the output is here to the primary motor area. Primary motor area. Okay, it is getting signal to the primary motor area, and these are reciprocally connected. Ventroposterior nucleus. These are sensory relay nuclei. The ventroposterolateral nucleus, it relays sensations of the head majorly through trigeminal and solitary or taste pathways, and its lesion lead to the the contralateral sensations of the face loss. and ipsilateral taste, and ventromedial it's getting sensations from below the neck, that is from the body, and its lesion will lead to the loss of sensation from the contralateral limbs. So the ventroposteromedial gets its signals from medial lemniscus of the decimal pathway and spinal lemniscus of the spinal thalamic pathway. And if you remember from the lectures of spinal cord, this is the third order neuron of these respective tracks. And the ventroposterolateral gets its signals from the trigeminal tract and gustatory pathways, taste pathways, including solitary and parabrachial. And its signal goes up through internal capsule, posterior limb, coronary areata, and up till primary sensory area, primary somesthetic area. It's present on the lateral aspect for head and neck, upper limb, and on the medial aspect for lower trunk and limbs. Other nuclei that were present are internal lamina, intralaminar nuclei, the midline nuclei, are reticular nuclei. The exact functions and connections are very vague for these nuclei, but the major role that can be given to this, the interlaminar nucleus, is sending the signal up to the cerebral cortex, to the different parts of the cerebral cortex, to keep it awake, to keep it conscious, to keep it aware, to keep it alert. If that nucleus is not functioning, the brain goes to sleep. So it gets its signals from different spinal thalamic tracts and different neighboring areas and reticular formation, and it sends signals directly to the cerebral cortex and sometimes to the neighboring thalamic nuclei, and from there to the cerebral cortex, and it is a part of reticular ascending reticular activation system through which the thalamus keeps your brain awake. That's why a lesion in this area may lead to a person going into the coma, because person may not get awake, yet not aroused due to the absence of outgoing signals. The connections I'm not going to discuss. I'm just going to flash you a schematic diagram of from the Inderbir Singh textbook of neuroanatomy. So it gets from collaterals from spinothalamic, trigeminal, and the different basal ganglia, cerebellum, reticular formation, and all that. And majorly they go to motor areas and diffusely to the other areas, directly or indirectly. The midline nuclei, precise function, maybe they are involved in memory and arousal, because they are connected to the limbic system. And again, I'm not going into the details of the connections. The connections are majorly in the cerebral cortex to the hippocampus and cingulate gyrus, and the hypothalamus, amygdaloid, pericortical gray area, reticular formation, nucleus ambiguous, nucleus ceruleus, and there are others too. Reticular nucleus, the one that was present outside between the external medullary lamina out to the lateral of the external medullary lamina and to the medial of the internal capsule, and its function is opposite of that of the intralaminar nuclei. Intralaminar was waking up the brain in response to the signals going from the thalamus, and this is the one that is receiving majorly from the cerebral cortex and influencing the thalamus. So this is getting major signal from cerebral cortex, different areas, reticular formation, and spreading its signal to the different nuclei of thalamus and keeping it functional. There is medial geniculate body. This is a part of auditory pathway. It's the relay center here, and it gets signals from both the ears, predominantly from the contralateral one, and the signals come from the inferior colliculus through inferior brachium. I discussed these structures in the front of diencephalon if you want to see where these structures are, and posteriorly behind it upstream, that is coming from lateral lemniscus to inferior colliculus to the medial geniculate body, and from there will be auditory radiation all the way going to the primary auditory cortex. Of course, there are some signals, there are some path fibers that are bypassing inferior colliculus, not synapsing there, but that's a debate for the auditory system, auditory pathway. The lateral geniculate body, This is the part of visual pathway, visual relay nucleus, and it gets signal from the optic tract for both contralateral field of vision. That translates to temporal part of temporal retina of the ipsilateral eye and nasal retina of the contralateral eye, and there will be opposite field of visions, that will be nasal field of vision of the ipsilateral eye and temporal field of vision for the contralateral eye. And it gets its signals from the optic tract. The optic tract itself was getting its signal from retina to optic nerve to optic chiasm to optic tract. Yes, there are some fibers that exit the optic tract to go to the reflexes. For pretectal nucleus, for suprachiasmatic nucleus, the pretectal nucleus are for the reflexes. The suprachiasmatic ones, these are the ones that are going to help in the circadian rhythm. And optic upward, they will go to the optic radiations to the primary visual area. This is the visual area that is present on the either side of the calcarine sulcus, superiorly in the cuneus, inferiorly in the lingula, and you can see them on the tip of the occipital pole too. So that's what that are all the nuclei. I hope I was able to make things easy for you. So every thalamic nuclei sends fiber to the cortex except reticular, because its major output is to the thalamus itself. Every part of the cortex sends reciprocal signals back. The thalamus and cortex are continuously in connection and in feedback with one another. Here is a quiz for you. You can pause the video at each point and go through that. Name the thalamic nuclei which different sensory signals relay. Sensory signals below the neck, ventro-posterolateral. Above the neck, trigeminal, ventro-posteromedial. Taste fibers, ventro-posteromedial. Visual, lateral geniculate body. Auditory, medial geniculate body. There is no direct, which signals does not direct pass through thalamus. All of the sensations pass through thalamus directly except olfactory. Olfactory does not pass directly to the thalamus. After relaying into the primary and secondary areas, it do come here but not directly. The blood supply of the thalamus, as you can see, it is majorly being supplied from the posterior cerebral artery and the posterior communicating artery. This is the posterior cerebral artery, the bifurcating two terminal branching of the basilar artery, and posterior communicating artery that was between the two, internal carotid in front and posterior cerebral in the back. So posterior cerebral artery is divided into P1, P2 regarding the part that is medial and lateral to the communicating artery respectively. And this on the medial aspect that gives rise to the subthalamic arteries. On the lateral aspect that gives rise to thalamo-geniculate arteries. These are the major aspect on the lateral aspect. This is the major one on the medial aspect. And then there is also posterior choroidal arteries that will go all the way to the front to supply the choroid plexus. Do you remember? The foramen of Monro was here in front of it, and choroid plexus was passing through it and above it. So it runs above it to the front. And from the posterior communicating artery, there is polar artery. That's about it. Clinical correlates when thalamus, it's there is a lesion, it leads to sensory losses, and because all the sensations are relayed here. So if there is a lesion of thalamus, there will be contralateral hemianesthesia in the beginning. So this feature is used for the surgical relief of pain too. Sometimes part of thalamic nuclei are damaged and intentionally, so that the pain does not relay to the cerebral cortex, especially intralaminar nuclei, part of them are damaged. Thalamic pain syndrome. Sometimes due to infarct, the ventroposteromedial ventroposterolateral nucleus get damaged and the person gets anesthesia, but after the injury that part tries to recover back, that part tries to regenerate, and when that's happening, usually very aberrant and abnormal signals are start uh, to be are sent up. For example, a person is just wearing the shirt and just a rub against skin maybe felt as burning of the skin, and he will start crying. And a tapping of the shoulder will feel like a hammer on the shoulder, and he will start crying. So these people are in very intractable pain. And thalamus, you remember that on the lateral aspect of thalamus is internal capsule. So any injury of the thalamus is usually involving the internal capsule too. That will lead to the hemi and paralysis. Thalamic hand, the ventral anterior and lateral nuclei, the motor relay nuclei that lead to damage to the muscle tone and all the different functions. So this is a typical position where the hand is pronated, wrist is flexed, metacarpophalangeal joint are flexed, and interphalangeal joints are extended. So this particular position is thalamic hand, and there are abnormal tremors like movement to chorioathetosis and ataxia. These appear in the thalamus too, and the hand too after thalamic injury. And as you saw in the pulvinar, lesion of the thalamus may also lead to a person develop aphasia. That's it. Thank you so much. I hope so it was helpful for you. If you have any questions, suggestion, and feedback, please mention in the comments below, and keep following us for more awesome comments on content. Thank you so much.